I, Iain Humphreys, am a private civilian speaking and interviewing my guests on behalf of the UK Medical Freedom Alliance. All parties participating are protected by the Geneva Convention. What follows are our personal experiences, observations and opinions, and the information is for educational purposes only. Those participating in these podcasts are professionals but are not providing medical or legal advice to you or to the public. The responsibility for the interpretation, due diligence and use of the information from this podcast lies with you, the viewer and the listener. Do your own research and use your discernment. It's not our intention to harass, intimidate, offend, defame, convey false information, cause non-trivial psychological or physical harm, or to conspire to blackmail, to coerce, or to cause anxiety, alarm, distress to any man or woman. The information presented here is done so with peaceful and honourable intentions. Thank you. Welcome to another broadcast by the UK Medical Freedom Alliance, the UK's most recognised and respected organisation advocating for every individual's right to informed consent, bodily autonomy and medical choice. We are the UK's voice of ethical medicine. Hi, welcome along again to UK MFA TV, our podcast by the UK Medical Freedom Alliance. My name is Iain Humphreys, and today we're going to talk about the new campaign that the UK Medical Freedom Alliance has just launched. A new campaign to oppose bills going through both Westminster and Holyrood. These bills which are seeking to enable terminally ill adults to get help from doctors to end their lives, known as assisted dying or assisted suicide. In Westminster, Kim Ledbett's private members' terminally ill adults (end of life) bill had its first reading on the 16th of October and will have its second reading on Friday the 29th of November. So today I'm joined by our CEO, Dr. Elizabeth Evans, and also the wonderful Clare Wills-Harrison, solicitor. And we're going to examine both the medical and legal ramifications of this bill and delve into it a little bit more and just start to unpeel the onion, if you like, and get underneath and find out just what it really means for not only the medical processes but the legal processes as well. So, without further ado, let's go and talk to Liz and Clare. Please consider donating to the UK MFA. We are really grateful for all donations, no matter how small. Your donations enable us to continue to lobby for your right to informed consent and medical freedom to be upheld, and to provide resources to educate and empower the public. There are multiple options for donating. One is that you can scan the QR code that's on this video right now, or you can go to the link that is featured in the description below this video, or you can go onto our website and contribute via donor box, or you can buy us a coffee. So I'm very, very pleased to be joined today by our CEO, Dr. Liz Evans of UK MFA. Thank you, Liz, for joining us once again. This is going to be a very important topic to cover, and we're going to try and get into some detail and have a good discussion about it. And to help us with her expertise is Clare Wills-Harrison. Thank you so much for coming along. And Clare, perhaps you could start maybe with an introduction about yourself and your background. That'd be great.
Yeah, no problem. Thank you, Iain. Thank you for having me on, and hello again, Liz. So most people probably watching this will know that I was a lawyer for 25 years. They may not know that I've retired. I retired in August for lots of different reasons, which we don't need to go into here. But I have got 25 years experience working in mainly an area of law that covers a lot of capacity issues, making documents, vulnerable clients, mental capacity cases connected with the Court of Protection, that kind of thing. So a lot of elderly law and working with a lot of people that are very, very sick.
Okay. And Liz, perhaps you just give a quick brief overview of UKMFA just for those that might be new to the podcast.
Sure. So yeah, we set up in October 2020, so 4 years ago now, to challenge unethical COVID policies originally. We are an organisation that campaigns on medical ethics issues, so that's informed consent, bodily autonomy, medical choice. And we spent the first 3 years really just fighting on the vaccines, the masks, all of that sort of stuff. But more recently, we're trying to put in a sort of commentary, an ethical commentary on anything which is impacting medical ethics. And I'm really glad to have Clare here, because I think this is a really thorny issue. It's a really complex issue. Obviously, because we generally have been, advocating for bodily autonomy, there are people who question, why are we against this? But I'm really hoping that this discussion will sort of scrape beneath the surface of what is on offer, this assisted dying bill, and show actually how it's not the answer to a very real problem, which we totally have a huge compassion for, this issue about people who are suffering at the ends of their lives. So I think both Clare and I hope, will be talking about, the problems with going down this route, and maybe looking at, what we could be doing instead.
And it's probably the likes of me that you need to get this across to, because I'm neither a lawyer nor am I a doctor, which makes me ideal placed for you to convince me of your cases and give me your information. So
let's just have a very brief overview then, so that we don't give people too much information. So this bill is going to provide adults with a terminal illness who are expected to die within 6 months to be eligible for an assisted death. Now, the person who is ill must have mental capacity to make the choice about the end of their life, and they must express a clear, settled and informed wish, free from coercion or pressure. And at the moment, the bill excludes disability and mental illness as eligibility criteria. There is another requirement in there, if the bill becomes law, that it will only be permanent residents of England and Wales that are registered with a GP for at least 12 months to be eligible. And apparently that is so that people do not fly into the UK to take advantage of this law when they don't live here. Now, there is a process to go through under the bill that we can probably delve into a bit more, but really that short overview is probably enough for people to understand what the bill is about, and for us to start a conversation, because it throws up already mental capacity, making the clear, settled and informed wish, free from coercion or pressure, and at the moment the exclusions and how they may be then brought into the bill further down the line because of the way that the bill has been drafted and how that can be enabled. So, I mean, Liz, do you want to say anything else about the kind of background to the bill as well?
Yeah, so I know that there's been a lot of, I think first of all it's a bit sort of alarming how quickly this has kind of come in and how quickly they're looking to get this passed. It's very much it's a sort of one of Keir Starmer's sort of missions, wasn't it, to try to get this heard before Christmas. It's a private member's bill. So it had its first reading on the 16th of October. I don't know if any of us were really aware of that. The second reading is on the 29th of November. So that's not a lot of time. And it feels like this is being done at breakneck speed, and actually a chance to have a really good, detailed discussion to, as I said, scrape beneath the surface and say, okay, what is the problem we're trying to deal with? Does this provide the answer? Because actually it's, I read a really interesting article last night saying that it's not as simple as just giving someone a drink and they just slip away in a few minutes. If you look at the stats on, places where this is happening in the world already, there's no regulation around the drugs used. There's a whole load of different cocktails used in different countries. Sometimes death can, be quick, but I think it's 1 or 2/3 of cases, I can't remember which way around it is, it's over 7 hours, sometimes as long as a week. And then and the physician, it's interesting, I was reading last night in the bill, the physician has to stay with the person till they're dead. But what if they start vomiting? Apparently 10% start to vomit, 4% come round again. What does the doctor do in that circumstance? What does the doctor do if this death is prolonged and drawn out over days and days? Do they have to stay there? Are they able to help them if they're in pain? because it's very clear in the under the legislation, they're not allowed to actually actively cause death. It has to be at the hand of the patient. So is that person then entitled to less medical care than they would have in a hospital if they were at the end of life, you know, on a morphine drip and, you know, being looked after, and if their pain increases, the nurse increases the morphine, keeping them, you know, pain and symptom free? It seems that the patient at home, say, having drunk the drink, is then on their own. I don't know, what were your thoughts on that? Because that, for me, that was a massive red flag.
Yeah, and in fact, I don't even think it's the doctor that has to be there. It's whoever takes whatever the medication is. And like you said, we don't know what that medication's going to be. So it might not be a doctor, it might be a nurse. And it does clearly state that they can't assist the person with taking the medication. So, you know, it is worth pointing that out, because that is different to assisted suicide. You know, it has to be that they're just bringing the medication and the person takes that by their own hand. But it does say in there that the person has to stay until the person has died. And like you've said, what if it does take days? What if the medication doesn't work? What if they do vomit it up? What if they're in really awful pain and suffering because of the medication that they've taken?
Doesn't it also say they don't have to be in the same room, though? They
yes,
can be nearby.
Yes, as long as it does say that. They don't have to be sitting next to the person. Being with the person can mean that they're in a different room. And frankly, I'll be honest with you, if I was in this position, which I wouldn't be, because I wouldn't be agreeing to it, you know, I'd be conscientiously objecting. But if I was involved in this as the person taking the medication, I wouldn't want to be in the same room, because have all sorts of things levelled at you. You know, where's the oversight of the person that's taking the medication as well, you know, to the person that wants to die? Is there anybody there watching? Is it, you know, is it going to be recorded? You know, what about allegations that actually that person with the medication did help the person to take it? So there's that as well, and possible legal ramifications coming from it. But I think Liz's point is really actually very good. If you take medication at the moment, putting this bill aside, if you were to take medication, Liz, to try and commit suicide, and let's say it didn't work and you were found by a relative on the floor, you would be taken to hospital, wouldn't you? And you would be, I'm assuming you'd have some kind of thing done to you to make that medication, make you either vomit it out or something else, and then you would be given appropriate care. You would be given psychological support as to why you maybe wanted to do this, one would hope. And you're quite right, what is going to happen to somebody at home that takes medication and doesn't die within 30 minutes or, you know, an hour, and they're still lingering?
Yeah, and I think this is the issue with the way it's being presented in the press, especially by the celebrity. You know, there's a lot of celebrities endorsing
it's been celebritised. It's my favourite thing. Everything's celebritised at the moment and done from an emotional perspective.
Yeah.
I'm really actually quite cross about the likes of Esther Rantzen saying, would you make me fly to Switzerland on my own to die? Well, yes, Esther, if that's what you want to do. I don't think the law should be changed for you.
Yeah, but also apparently there was I was reading an article yesterday, a very good article, which gave me more pause for thought, and this issue around drugs came up. But Dan Hitchens wrote in Unheard the painful truth about assisted dying. But he was saying Terry Pratchett apparently said he wanted to die sitting in a chair in his garden with a glass of brandy in his hand and Thomas Tallis on the iPod. But that is such a fantasy vision. I think you cannot take away the fact that the act of death and taking your own life, this is still suicide. You know, you are being forced by this bill to do that yourself. It's nobody's doing it to you. It's a violent act. And I don't know whether medicalising it and making it appear clinical is going to be any less violent you know, in the sort of emotional and sort of spiritual way to what you're doing to yourself than were you to go and, you know, take your life. As you said, you know, that people do take their lives, and it, you know, it's a tragedy. And possibly it may be more prolonged and less humane if things aren't quite as quick and easy as you're being sold it. So I worry people are being sold something which actually is not deliverable. At least it's certainly not 100%, it's not 100% deliverable. We have the data to back that up, but you know, is it even 50% deliverable? And what about the other 50% of cases, or whatever the numbers are?
I think it's a really good point that you make, because it's, and I hate to say this about something so serious as somebody thinking about taking their life, and you know, I'm not in that position where I'm very unwell, so I can't say that I know how that feels, but it's very, in some, with the celebrities as well, it's very over romanticized, that, which I think is the point that you're making. Dying is a natural process that we all go through, and when you force that rather than it being a natural thing, it can actually be very painful. The other thing is, and I'm not sure that people fully understand this, there's no requirement for anybody that wants to go down this route, if this bill becomes law, to speak to their family about it and tell their family. So this could all happen, and we can talk about the timescales here and what, you know, the issues that brings up. This could all happen very quickly, without really the involvement of your family, without people talking to their family. Now, I'm not saying that people wouldn't talk, you know, it's a big decision, and perhaps lots of people would, but some people wouldn't. And you have to wonder as well what that's going to do to the people that are left behind, and how they're then going to question the capacity of the person that undertook this process, whether they were fully informed, informed consent, whether they, and I've got all sorts of other issues as well with it. For instance, Liz, you're a doctor. Can you tell when someone only has 6 months left to live?
No, I think that's very well documented as well. It's all very well, you know, in the law it says expected to have 6 months, but it's a completely inexact science to be basically kind of foretelling the future. You know, doctors are often right, but then they're often wildly wrong. You hear of people who were given 3 months to live and are still alive 3 years later. So there is, it's almost, I think the problem that we're doing here is we're trying to take a natural process and put human beings in control of it, in a sort of a, you're kind of asking doctors to play God.
Absolutely.
You know, to have this power over life and death. So not just to be there to heal, but to kill. And I think that's a massive conflict that's going to create in the medical profession, and it fundamentally changes the relationship between the patient and the doctor when the doctor can have two hats on. Where was I going with that? There was 2 points I was going to make. So yeah, the doctor kind of, and also that he's being asked to be able to foretell the future.
Yeah.
You know, which human beings have always tried to do. We look back and we saw people went to fortune tellers, or, you know, these people who read the stars and were trying, you know, human beings have always wanted to know the future because we've always had this great fear of death. You know, that's part of the human condition. And I think it's just naive and a fantasy to believe that science has finally sorted this out and we no longer need to fear death because we can manage it. And I think you're opening a Pandora's box because, you know, yes, you know, possibly for some people this does, you know, give them a really, you know, peaceful death. Okay, so let's assume that this can work. But it won't work in all cases. But also, what other collateral damage is going to be done? You know, how do the safeguards which are being promised in all of the, you know, I've read most of the bill. I can see she's really tried to put lots of safeguards in. But the trouble is, we know already from all the countries that have introduced this sort of legislation, the safeguards go quickly. You know, within 3 or 4 years, Canada has gone from, you know, very similar to what we've got with all the safeguards to pretty much anyone can ask for assisted, it's called MAID, isn't it? Medically assisted dying.
Medical assistance in dying.
So you've now got it extended to children. You've also got it extended to people who are mentally ill. You've also got it extended to people who are in poverty or who just find life, they'd rather just not live with no medical reasons. So we know what human nature is like, and I think this is the point of medical ethics, and I think this is why we have taken the position we have, is because we say that medicine is inherently has a power imbalance between a doctor and a patient, and there is so therefore there is always the potential for abuse. There's an intimacy there where the doctor has the power and the patient is vulnerable, particularly when the patient's suffering. So we have to always use a very clear boundaried ethical framework to ensure that there is no abuse within that relationship between a doctor and a patient. And I think, I'm sure this is a well-known sort of idiom, hard cases make bad law. Just throwing medical ethics out of the window because we've got a problem and these people are like really suffering. So let's just get rid of the first do no harm. Because actually in this case, autonomy trumps all. But the point is you've got to balance everything and have the wisdom to see what else can come from trying to just do good for one group of people. Because I think we're naive if we think that this won't have massive ramifications and that innocent people won't end up being bumped off by the state, effectively. So I think that's why we're taking the position we are, because I think our system will not be able to deliver this in a proper, safe and ethical way. I don't think that's possible.
Well, I'm kind of scratching my head, if I'm honest with you, over the need for it, in the sense that if you are in the position that you're well enough to go to a doctor to say, can you sign me off because you think I'm going to die in 6 months, and I want why wouldn't, I'm sorry to bring it down to this level, but why wouldn't you just take your own life? So why do we need the state to be involved in that process, is what I'm saying. I'm not against anybody doing what they want with their own body at all. Body autonomy for me is key. What I am against is the state becoming involved in this and dragging doctors into it and dragging other people into it, because that's what's going to happen with this, which I'll explain in a minute. So my question is, if you're well enough to go through that process, because this bill says you have to be well enough. It says you have to have the mental capacity. It says you have to be free from coercion and duress. So you have to be at a certain level in yourself to be able to go through this process. So if you're at that level, why do you need to go through this process?
Can I just play devil's advocate for a minute and say, but what about those people who are completely incapacitated? So motor neurons disease and that kind of thing.
Okay. Let me answer that for you, Iain, because that's a really good point, and it's one of the things that I'm really worried about with this, okay? So this, as I read out to you at the beginning with that very brief overview, the person must have mental capacity to make the choice about the end of their life. Now, I've looked through this bill and it says that mental capacity means the definition within the Mental Capacity Act 2005. So that's the 2-stage time and function specific test to determine mental capacity, which Liz will probably know about as well. So the Mental Capacity Act 2005 asks, as the first stage, does the person have an impairment or disturbance of the mind? Now, someone with a brain illness, motor neuron, other things as well, fails that first hurdle, and you then have to come down onto the next, okay, the function specific. So you have to assess somebody's capacity for this, and one of the key assessments is that they must be able to communicate their decision. Now, that doesn't always mean that somebody needs to be able to speak, because there's other ways of communicating, but there becomes a level, if you are that severely incapacitated by an illness, that it is very difficult to get somebody over that hurdle of having the capacity, because they can't communicate their decision. Another head is that you have to be able to retain the information to weigh up things and be able to demonstrate really that you can do that. So to me, this bill doesn't even maybe cover people that are in that situation, because they're almost excluded from it because they're not going to be able to get over the capacity test. So we're talking about people that have the capacity, and for me that makes me feel that we're talking about people that are actually at a level that if they really wanted to take their own life, which is up to them, I would hope they wouldn't, and that there's another, other ways that we could help them. But if they were at a level to be able to pass these tests, that they don't need a doctor to sign them off and to have anybody else involved in it. It's a decision that they can make for themselves. We don't need the state.
Find out more about the UK Medical Freedom Alliance on our website. That's at ukmedfreedom.org. That's ukmedfreedom.org, where you'll find all the information you need around open letters, our campaigns, our legal template letters, and of course, even these podcasts. You'll find details of the latest one, and you'll be able to access the previous ones too via the links there. Find out more about our team. Sign up for our newsletter. It's all there, and you can even donate too.
You could have somebody, in my opinion, and Liz may disagree, and that's fine, but you could have somebody that actually does only have 6 months to live, but actually isn't in a lot of pain and doesn't have a lot of difficulty in living. And you could have somebody actually that maybe might go on for 5 years that's in a lot of pain. They're not going to be able to qualify to end their own life under this bill because of the 6 month terminal illness. At the moment, I suspect it will get expanded for equality reasons beyond that 6 month, for the reasons I've just told you, because somebody that could go on for 5 years that might be in pain, it doesn't qualify. So, I'm scratching my head over the necessity of this with the way it's been written. And there's a very big part of me that sees this as an enabling act for expansion because of the way that it has been written. Okay, so it comes in as it is. And like Liz said, it's got these inbuilt safeguards, which actually I actually don't think they are safeguards, if I'm honest with you. Doesn't cover people that are expected to die more than in 6 months' time. It's quite difficult, as Liz has said, to forecast when somebody's going to die anyway. But of course, once the act's in place, then the expansions can come in when people start to complain, well, I've got 2 years but I'm in pain, or why shouldn't it cover me, my human right? I've got human rights, why shouldn't it cover me for this or this or this? Okay, and what you have in this bill is a Henry VIII clause. Okay, and if people don't know what a Henry VIII clause is, it's a clause that's inserted into legislation that enables the executive, and when we talk about the executive, we mean the kind of what people would refer to as the government of the day, although government is the 3 branches of government. We're talking, so think of Keir Starmer and, the cabinet and all of that. It enables the executive, a Henry VIII clause, to come in where there's an act of parliament and to just repeal it or amend it without any further oversight. So no parliamentary debates, no going through people looking at things and MPs debating it and saying no or yes or whatever. We've got Henry VIII provisions in this act that potentially could expand things without any further scrutiny.
Is that, just to clarify, because I was reading this and some of this I didn't understand, and that's the negative procedure.
Correct. Yes.
The mention of regulations under subsection are subject to the negative procedure, and I wrote, what does that mean? What there is that's your
yes.
Clause. So that's where, and you, if you look at things, there's quite a lot of bits later on in the bill which sort of says codes of practice, codes and guidance. So then it basically defers to the Secretary of the State of the time to determine what drugs are going to be used.
Absolutely.
Various things within it. So that's not legislated for at all. So that is an area where immediately you've got an unknown. You've got the chief medical officer is asked to prepare and publish various things, and needs to publish guidance and little protocols about what palliative care should be offered, what drugs should be offered, what, all sorts of different things which are not. And this is where you get these bits which can radically change from one chief medical officer to another, or one secretary of state for another, or you have the NHS in total, meltdown crisis. There's no funding for anything, so they say, well, look, let's just say that anyone who's got a terminal diagnosis, this is the first line. That could very conceivably happen, or that they're automatically offered it.
Yes,
because which is what's happening in Canada now.
Yes, and if this act was not going to be expanded, it wouldn't need to have the Henry VIII clauses in there. Let's be honest. Mm-hmm. Let's be honest. They're always argued as being necessary in case they're needed in an emergency. Okay, but let me just explain the negative procedure for regulations for statutory instruments. They're brought in by statutory instruments, so the secondary legislation. So basically, the negative procedure means that the statutory instrument gets laid before both houses of Parliament and automatically becomes law within normally 40 days, unless either house objects. And during that 40-day period, there can be a motion to annul the statutory instrument, and it doesn't happen a lot because there's so many statutory instruments that go through, and I mean there's 4 or 5 times as many statutory instruments as primary legislation. You really can't keep on top of them all unless you're focused on a particular area, and it just overall leads to less scrutiny. The affirmative procedure is different. We have an affirmative procedure where it does require active approval. It's still subject to annulment, but lots of things are brought in by this negative procedure. We saw it during COVID.
I was going to say that was Matt Hancock ruling by decree for so long by just putting in statutory instrument. So you can imagine in an emergency situation how pieces of primary legislation like this could be abused.
Yes.
To sort of not mandate but create protocols whereby assisted dying is suddenly needed.
Yeah, and expanded.
Save the NHS.
And well, precisely. You do wonder, don't you? Stay at home, take assisted dying, save the NHS, that kind of mantra or whatever. I mean, and we laugh, but it's no joke really, because this the negative procedure and this use of statutory instruments is so nefarious with the way that it's altering our laws without proper scrutiny, and the average Joe, the average person, is just unaware of all of these statutory instruments that are flying through all of the time in, say, 40 days, 6 weeks. And the negative procedure, you see, should be used, or it's said that it's used for statutory instruments that are considered less controversial or less impactful. Now here you have the ability in this bill over assisted dying, or the expansion of it. That's not less controversial or less impactful. It's a really fundamentally important topic that all of us should be involved in and engaged in. And one of my concerns over the use of a statutory instrument is with respect to the meaning of the word doctors in this bill. Okay, so when you read through the bill, it clearly states that the coordinating doctor, for instance, means a registered medical practitioner. It doesn't mean a doctor, therefore, does it, Liz? Am I right in thinking that?
No, because there's many registered medical practitioners within, say, nursing, pharmacy, physiotherapists, occupational. I mean, there's all sorts of people who are registered medical practitioners under a registrated body. So
there you go, because it says in this act the coordinating doctor means a registered medical practitioner who has such training, qualifications and experience as the Secretary of State may specify by regulations subject to the negative procedure. So you could,
and also, so I'm thinking there's been a lot of, it's quite a scandal that they're bringing in these physician's assistants who haven't been through a medical degree, have a very short training and are coming into general practice, but it's not obvious to patients that they're not actually dealing with a doctor. They've got someone who's kind of a sort of, I don't know, they're not even apprentices. They're a less trained person who's trying to be a medical technician, I suppose, and also following protocols. So a big bugbear of ours in the UKMFA over the last few years has been the sort of the derailing of the doctor-patient relationship by the use of protocols. So everything's top down. So, a doctor will, make a diagnosis, then reach for the protocol, which has been written by some distant bureaucrat as a one-size-fits-all. You take this drug, this drug, this drug, this drug. This is your order, and no longer is it kind of individualized care. No longer are you using the experience, the wisdom, the intuition of the doctor saying, well, I personally think that you would benefit more from this drug, but my patient this morning I didn't think that would work for him. You're de-skilling the doctor, where you've got these physician's assistants who are only really following protocols because that's the only way that they can practice. But that's not good for the individual patient, because what works for the majority won't work for everybody, and will cause harm in some people, whereas it might work for others. And I worry that you're going to bring in protocols very quickly. That this, as I think you said to me before we started recording, this is going to become a tick box exercise. That actually, just the procedure that's required, you have to go to your doctor. He has to make sure you're not being coerced. He's meant to be interviewing your family and various other people, and then you've got to go to a court, and then you've got to have another doctor. How? No one can get an appointment for months at the moment in the NHS. How is this going to work and not be? How is anyone going to actually follow the letter of the law? And who is going to go after them for not following?
Yeah. Well, this is it, isn't it? I mean, there is some stuff in the bill about, if someone's found to be coerced or whatever, but if enforcement of that, are the police going to have time then to look into all of this? But you make a really good point about the guidelines, actually, because, and I can't remember where I saw this, and I'm sure it was either in the bill or in some commentary about it. And when you're talking about guidelines, can I just ask you, it might be more than this, but are you generally talking about things like the NICE guidelines? Those
NICE guidelines, or just general hospital protocols and policies of things,
because
general practice guidelines.
Yeah, so I have a problem with NICE guidelines for the same reason that you do, and particularly over the last 4 years, I have a problem with those guidelines. Especially the ones that were brought in very quickly at the beginning of COVID, and we've seen those guidelines actually used to some pretty awful effect with respect to end-of-life medications and things like that. And there is a COVID inquiry, there is the Scottish COVID inquiry, the UK COVID inquiry, which has some very damning testimony about that. So I have a problem with NICE guidelines, and I completely agree with you, because we see this in the law actually quite a lot, that we have precedents when we draft documents, and if you're not an experienced lawyer that knows, well, that clause doesn't need to be in there for that document, it's left in, and it causes a problem. And this is because there is a dumbing down, a skilling down of the legal profession, in the same way with the use of precedents as there is with doctors, with the use of guidelines. It like you said, it takes away that individualised, patient-centred care by looking at your book and saying, well, this is what it says, and a good doctor doesn't do that. And unfortunately, doctors are pressed for time. Like you've said, there's these these physicians that are coming in and just doing that, and we've seen the same in legal practice as well. So I have a real problem with guidelines, and it does say that it's going to be NICE that are going to draw up these guidelines. And I can't remember if it's in the bill or if I've read that outside of it with some commentary, but I saw NICE because I remember I took a sharp intake of breath and thought, well, here we go again. Okay, here we go again. And there are one size fits all, and like Liz has said, it just doesn't work. And I'll be honest with you, isn't this really as well just an excuse not to improve palliative care options for people?
Absolutely. And I really wanted to talk about palliative care because I think it's definitely the case that high quality palliative care just isn't available to everyone at the moment. And I think that is, shameful. And we should be doing absolutely everything we can to lobby for more good quality, because palliative care consultants say if they can give good palliative care to people, it is a myth that anyone should have a really prolonged, painful death. So with good palliative care, usually in a hospice, hospices are the best place for that, under a consultant who can titrate your drugs. And it's patient-centred, isn't it, again? And it's not just about the management of physical symptoms, it's about dealing with emotional and spiritual healing during that time, and support, and helping people to have difficult conversations and make peace with various things, so that people can have closure before the end of their life. I've seen a very good death, a very untimely death, but in a hospice, someone far too young, but the care and the way it was managed, it was a very beautiful experience while being very, very tragic. And I think, we're being indoctrinated with this terror of death, this thing that we just cannot, I think a lot of people are making a decision that I want to end, if my life's going to end in 6 months, I don't even want to be there for that, so please just take me away from it now. But not recognizing that there can be gain in suffering, and that some incredible healing on a spiritual and an emotional level can occur in those last few days and weeks if a death is managed well with the appropriate support, and not just the drugs, but the counselling, the spiritual leaders, whatever is needed, and the family coming together and being together. And I think this sort of clinical approach of assisted dying dehumanizes us to a degree, because it's sort of almost trying to deny the reality of the human condition. We will have suffering, we know that, but also that in that place of suffering, it brings out people's humanity. The people around them are forced to be loving and compassionate and kind and selfless, and actually doesn't that enrich all of us? And it worries me that if we just see death as a valid treatment for suffering, actually it diminishes us as a society, not just the individuals involved, because it's a much more utilitarian view of life. It's like when you're no longer productive or able to do X, Y and Z, then there's no point in your life anymore. I think personally I believe in the intrinsic value of every human life, which doesn't mean I would seek to fight death, sort of artificially prolong life beyond its natural. But there's a very big difference between heroic measures and giving chemo after antibiotics and all this sort of stuff, which I think is there comes a point when someone is dying, so you've just got to be there for them, hold the space for them, give them all the support they need, and allow it to happen. Because it was interesting. There were some studies I saw. There were 2 studies that compared quality of death by assisted suicide and by nature taking its course. They were done in Oregon, where assisted suicide is legal, and in the Netherlands, and they both concluded that they were as good or bad as each other. So actually, you don't improve on, having a natural death. So why would we even go there, given that the collateral damage, the innocent people who end up dying because your choice to die very quickly will become a duty to die when you are a burden on your family or on the state or on whatever you perceive your burden to be. And we know from studies in Oregon and Canada that many people put being a burden as one of their top reasons for requesting assisted suicide.
Yeah, and I totally agree with you about the way that I think people, the death process is, if it's managed correctly, can be actually such a really beautiful time for families. Listen, it's sad, we all die, and it's horrible when somebody dies young, but I like you, Liz, have seen so many families where that's happening, and it's become an experience for them that has wedded them together in different ways that, you know, you would never have thought of. The compassion,
kind of life affirming.
Yes, exactly. And the beauty of what life is because of that process that somebody that they love is going through. And this is kind of like this medicalisation of everything, isn't it? And the way that we see it, you know, science and medicine can stop suffering or whatever. And like you said, where it actually you can have a lot of spiritual growth through the process of suffering, of being ill, and as can your family. And this is just taking that away and saying, look, do you know what, you're gonna die, let's just put you down now, like a cat or a dog. And people who raise that argument all the time, you wouldn't let an animal suffer. Let's just roll that back a little bit. Animals can't speak, they can't tell us what they want, we don't know how they feel, and we are not animals in the sense. We're very different to cats and dogs and things like that for obvious reasons. So it's not the same. And nobody is suggesting that anybody should suffer. What I think we're both coming from the perspective is that there's actually a massive problem with palliative care services in this country, and there has been for a long time. It's underfunded. I mean, hospices don't get any central government funding, do they, Liz, at all, I don't think.
No, because I think a lot of them are charities, aren't they, at least?
So
they're all charities. Okay.
You know, we have to consider that if the government was serious about making people with terminal illnesses more comfortable, and for their deaths to be less painful, and there would be more funding for hospices and things like that, and there would be better palliative care services. We also have horrendous social care system in this country that is, you know, not performing for the residents that are in care. And I do think that one of the big things that could happen with this bill, if it becomes law, is that it will expand to people potentially that are actually, a lot of them are in social care. When you start to get to that level, you start to get to the level of money, okay, and you start to get
dementia patients, for example, who you know are absolutely, you know, expanding at a rate of knots, aren't they? And they're filling up the care homes, and many of them have years to live.
But you've got
think, you know, cause my mum's got dementia, so, and she's in a home at the moment, so I have personal experience of it, and I would not want to have that condition. It's horrendous, but I don't even feel that she is suffering that condition. So it's like, how can we, healthy, young, you know what it is to be in that position, and then make the decision that life's not worth living? I think it's, you know, it's purely subjective, isn't it, at that point?
I mean, and if we do get an expansion to that, where we knock out the requirement to have capacity for yourself, and that somebody else can make this decision that your life's not worthwhile, which is kind of the way it's going in Canada, you know, the way it's going. It's not quite there yet, but even if you've still got capacity, can you imagine if you were in a home that's costing £4,000 or £5,000 a month, and you've got children or relatives that are watching your finances dwindle down on this, and this is where I want to come on to the coercion and duress, because we see it all the time in the legal profession, and it doesn't matter what safeguards you try and build into this, it's not going to work. I've seen this over 25 years. So when you talk money, when you're talking about money with people, now I'm not suggesting this is in the bill already, as I've said, because it's limited to the 6 months terminal illness. What I'm kind of looking at here is the slippery slope, because of what we've seen in other countries if this gets expanded. And when you start talking about elderly people, and actually you look at the way that they are positioned in society as being a burden, actually, that's the messaging that comes across really from central government and local government and actually society as a whole, they don't, they're not the state pension's costing us this much per year to fulfil. These people don't pay sort of, anything in anymore. And we have, as a society, we have the point of view that actually we should take our elderly relatives that can't really look after themselves that well anymore and shove them in a care home. And I mean, that's another conversation about whether we should be looking at this completely differently, in the way that other societies do, that have that know that there's intrinsic value in their elders and the experience and the knowledge that they can pass down, and they're revered almost, and they would never be shoved into a care home. And we get to the situation that if this gets expanded, that I'm sorry, but I've seen it, you're going to have children that say, if he goes on for 5 years, that's all our inheritance gone on care fees. And then the coercion starts, and it's not holding somebody's hand to the piece of paper, it's subtle. It's subtle, it's making them feel like they are, it's psychological, it's making them feel like they are a burden, it's making them feel like their life hasn't really got that much value. Well, you've had the best years of your life, we've got our lives to live, and we're struggling with our mortgages, and it's terrible. And it's not even said in a bullying way, it's just fed in all the time. And I can tell you with my hand on my heart, okay, as a legal professional, you are never 100% sure about whether there's coercion or duress going on, despite your best efforts to get to the bottom of anything. As a lawyer, and I'm sure doctors have this, you have what I would call a spidey sense about things, and you think this doesn't feel quite right. But if you go through everything that you're supposed to go through, and the person in front of you is telling you that they're not under duress, there's nothing else that you can do, and then you find out later on X, Y, and Z, not so bad with a legal document, because we can undo it. Very bad when you're talking about somebody ending their life and being signed off for it. It can't be undone. And so
I think it's also a completely unreasonable expectation that the doctor, who has to, by law in this bill, establish that there's no coercion, but practically how on earth
you can't
do that? And how many conversations, I mean, you'd have to visit the person in their home, really, and sit around and spend time with people. So I think in a way that's just a false safeguard, because it cannot practically be enacted.
It's what we call in law lip service. Because listen, we spend more time talking about duress and undue influence and considering it for somebody making a will than what this, what we have to consider. So there's a whole raft of case law around stuff like that and around document making that we have to know about. We have to learn about that. I'm sure doctors don't know that, they don't know the case law. And equally, like in my experience, if I ever had concerns about something like that, and I saw a client on their own, which you have to, and I still had concerns, you then start getting to the stage where I would be, in practice, I would have thought, right, well, I'm going to go and visit that person at their home, in their home surroundings. I'm going to see what the people are like. I'm going to see what I pick up from that. I'm going to see whether the person seems different when they're on their own and whether they're in. You have got no chance of any doctor going to do that. And this whole process under this bill, evidently, could be as short as 21 days, okay? So you've got your first doctor, your second doctor, and the court hearing in 21 days. Now, given where we are with GP appointments, nobody can get them, given where we are with backlogs at the court, how is this going to be anything other than a rubber stamping exercise?
Yeah, because it won't be, there'll be so many people then who want to, what if they get 10,000 people in the first 2 or 3 months who want this? There's going to be a massive protest if they can't physically get through the system. So then you're going to almost have to set up a system which which allows it to happen in the right time frame as quickly as possible. And I know one of them said if your expectation of life is only a week or two, then it could come down to 48 hours.
Correct.
Yeah. But how is that actually feasible? So, Iain, you have some experience of Switzerland, don't you? And you almost end up then in a case where private companies would have to just take this over.
That's where we're going.
Yes. Would you just talk about that?
Well, yeah, I mean, I know people in Switzerland and who have experienced this. There's the kind of scenario where they're just looking out the window and they've seen the Dignitas or exit vans arrive. They go in, and then 15 minutes later they're coming out with a body on a trolley and they're gone. So it would apparently be a fairly swift process by the sounds of it, but who knows? I mean, you don't know what's going on behind the closed doors. I've also got a friend whose mother chose to depart recently. I'm not absolutely certain of the circumstances, and I would want to double check in case I'm speaking out of turn, but I was under the impression that part of the reason was this: I'm a burden on my daughter and my family, and it's time for me to go. And I think that when I talk around the family in Switzerland, they talk about it as it's part of the culture. So they talk about exit and Dignitas as part of their everyday conversation. They sign up well in advance, and it's a commercial contract. Or you're paying a small fee every year to become part of the club, so that when you're ready, you can say, "Oh, I'm off now," and you go in and sign the paperwork. They give you the sweet drink, and you're dispatched. Now, that's almost glamorous, actually, in a way, because that's the way that Hollywood presented it as well. I mean, I can't remember the name of the film now, the book. It was it You to Me or something You to Me? I can't remember. Yeah, but the guy just chooses to dispatch himself at the end, but it's all done, in his beautiful room, and there's this little cup, and they give him the cup, and he drinks it, and he's gone in like 3 minutes, and it's all over. And as we know from the reports that we've seen and some of the other anecdotes, it's not quite like that, is it? And if it was that easy, Liz and I were speaking again before we were recording, we said, but if it was that easy, well, then you wouldn't have these reports from Oregon and from Canada and the Netherlands and these deaths that are drawn out, because surely there would be this one substance that would act that quickly, and therefore there wouldn't be so not an issue. Depends on where you come from, but you know what I mean. It's like, well, there's a lot less to talk about if that's the case. Mm-hmm. So yeah, it's that's the experience that I've got from the people that I know in Switzerland that are using the system.
What occurs to me is that this is a very expensive, actually. So I know people sort of think the NHS is free, but actually this is taxpayers' money. To go through all these different checks and balances, court cases, paying lawyers, doctors, independent doctors, someone to come and sit in your house potentially. I've got actually the stats here, so I want to just clarify. With oral methods, 1/3 of assisted suicides take between 90 minutes and 30 hours. Up to 9% have trouble swallowing the dose, up to 10% vomit it up to 2% and re-emerge from their coma. There was a Dutch woman with Alzheimer's who recovered consciousness and was held down by her daughter and husband while a doctor finally actually put her out of her misery. So that's against our law, but what would
I would say that's against all law. I mean, so this is something else I wanted to bring up, because I think this is really important, and it seems to be really grey in terms of the way the law works. If you undertake to dispatch someone that way, so in other words, they haven't died within that period, and actually that brings me back to the Swiss experience. What people have been witnessing maybe is just a collection of a body after a few days. It might not be the fact that they've just gone in, done it, and come away. So so they're just assuming that actually it was all done within a very brief period of time. Maybe it's not. But once you start to intervene, you must be committing a very, very serious criminal offence, and it must be almost murder.
Well, yeah.
because you're a bit I mean, in law, I mean, I was a policeman for 10 years, so I mean, I've still got my memories of all of that, and you could not consent to any serious harm. You can't consent to grievous bodily harm, and you can't consent to murder. So therefore, the law kind of, for me, it feels like it's creaking towards serious criminal law at that point. And you're viewing it from a completely different perspective, and I wonder if these doctors actually understand how close they are to that point, because if they're assisting in a suicide, and it goes wrong, and then they intervene, thinking they're doing the right thing.
Yeah.
But at that point, they're not, are they? They've now moved out of this act into criminal law.
Under this act, they would be prosecuted. You'd have
So
the burden of proving it, and it would be difficult.
Horrible position, because actually, you're trained to go. If somebody gets knocked over in the street, as a doctor, even now, I haven't practiced for a couple of decades. My instinct is to run to help them, because that's my training, and I know I want to do something. How a doctor's going to be able to sit there if things go wrong? So I was reading a really good, there was a paper in the Journal of the Association of Anaesthetists talking about legal and ethical implications of defining an optimum means of achieving unconsciousness in assisted dying. and it says that with self-administered barbiturates, death does result slowly from asphyxia due to cardiorespiratory depression. So essentially you're kind of suffocating to death. There is a high instance of vomiting, prolongation of death, reawakening from coma. And it's the assumption that an optimal method to achieve unconsciousness and subsequent death already exists. There's this assumption there, but it doesn't. There's a real problem. We can't know whether the patient's unconscious at the time of death. Anaesthetists struggle with this in theatre when they've got all their instruments, they've got, multiple different drugs, and they're giving little doses, and they're adding a little bit, taking a little bit away, because everybody reacts differently to drugs. And they've got, the ability to try to sort of work out consciousness. But, you're not going to have this. How do you know that this patient who is flat out is actually unaware of any pain they're going through?
They've
had the same problem with.
Yeah.
They've had the same problem on death row with lethal injections. Same problem.
Yeah, absolutely. Yeah.
And it says, so the fundamental point is the evidence base is inadequate. No drug regulatory authority anywhere has approved any drugs for use in assisted suicide. There's been little or no research on their recommended combinations, and no peer-reviewed literature to guide best practice. So, that work surely has to be done first before we start introducing anything like this. It feels like there's a sort of assumption that it'll be okay, but this is a massive change in it. I say it's a Rubicon that you once you've crossed it and you've allowed the state to legally sanction their agents to dispatch somebody or to help somebody kill themselves, it changes everything, and it's going to have huge impact. But I just wanted to spend the last few minutes talking about the sort of there are some really good arguments for it, which we are constantly being challenged by, and I really do appreciate people challenging me, because it really has made me think, because I don't think we can be glib about this. When I first came to it, I thought, well, to me ethically it's obvious, but actually when I've heard the arguments, they are compelling. So people will say things like, dying people deserve the choice to control the timing and manner of their death, and it's a personal choice to have a peaceful end. So what would you say to that?
Well, if I'm coming at it from a spiritual perspective, nobody has the right to control when they die, and I guess that comes down to your belief structure as to whether it's a natural process and it's connected to God, and when you're born and when you die. So I actually don't hold that view. I don't believe that any of us intrinsically have the necessarily could argue that we have the right over and above God, but also I recognise the fact that people can commit suicide if they want to. And so if I were to agree with that, which is a body autonomy thing, so I'm kind of flip-flopping here, but again, you've caught me on the hop, so thinking about it, then yes, you would say, yes, you're entitled to control that, but you don't need anybody else to be involved in that for you and helping you and for the state to legislate. And by the way, there's nothing to say that your death will be painless given everything that we've just spoken about. I mean, it's a horrible thing to ask, but I don't know if any study's ever been done regarding suicide and the methods that people use as to perhaps what the quickest and what the least painful is. You know, like I think we had a conversation before we went on, and you know, people that perhaps have committed suicide by hanging themselves, I think you said it's probably quicker and might end up being less painful than if you were given a cocktail of drugs to do that. So, you know, that argument that we're all entitled, I don't know, I really have difficulty with it. I just have difficulty with that concept. That's almost getting to the stage of saying I don't want to bring it back to this, but everyone's entitled to just wake up and decide what gender they are on any given day, or if they're a hedgehog or whatever. You know, it's just getting into, I know it's more profound than that, and I know it's a deeper question than that, because we're talking about dying. But, you know, if you're of the opinion that you have the right to be in control of your own death, then that's something that you should be taking into your own hands. You don't need the state to be involved in it, I think, is where I would sit on that.
Fund it, because the state isn't just being involved in it and enabling it, but it is also funding it.
Yeah, I'm paying for that. You know,
it's a big ask of the taxpayer to fund your kind of. And I think at that moment where you have the cup in front of you, and you know that you may be sick, it may hurt, you will suffocate to death, I don't think it's any less violent and any less terrifying. And I think for me, I would rather be in a hospital bed, you know, if I was in pain, saying, can I have a little bit more morphine, please?
Surrounded by your family.
Nurse to be able to manage symptoms and to trust that, you know, that there is that care there. And I think, you know, isn't it interesting that the vast majority of palliative care consultants say, no, we absolutely should not go down this route, and it, you know, that there is no, you know, we can manage pain, we can give people a good death naturally.
Yeah, I need to push back on the suicide thing a little bit, just from my personal experience. Now, I was a police officer for 10 years. I actually dealt with a number of suicides. One of the first things I ever did was a suicide. As a policeman, first thing I had to report and was actively involved in. It is horrible. It's horrendous. Not for the person that committed suicide, because in fact the majority of the ones I dealt with, it would have been very, very quick and probably pain-free. Actually, they would have known very little about it. But the ramifications of it on the police service, the ambulance, wherever it's actually happened, the people in that environment, the family, it is just horrendous. So I think there is a balance to be had there. Yes, if you want to take your own life, fine, but probably again you need to be somewhere where it's a little bit more you know what I mean, a hanging or something like that. It's someone's got to find that. Someone's got to deal with it later. And they might not even deal with it on the day. It could be 2-3 weeks later, and that's even worse. Believe me, I've seen it. So you don't want to experience that. So, and the other thing that I'm also worried about is the effect this also has on the doctors, though. So on the other side, where the doctors are helping someone to die, so as you say, it's assisted suicide essentially. I wonder how many of them would really deal with that well psychologically. You know, because it's different giving someone medical care and doing your very best for them, but to help them die, I think, is probably a different thing.
There's some stats on how many. The majority of doctors don't want a part of it. Yeah. So even though some of them will support it, some of that group will support the option, they personally don't want anything to do with it. I know the BMA has come out as neutral more recently in the last couple of years, I think 2020 or something like that, against it, whereas they always stood against it. Looking around the world, most medical kind of bodies stand against it. The Royal College of Surgeons are for it. So, you know, there are mixed views within doctors, but there's been a really good letter actually looking at calls to action on our website. Please do go to our campaign page, because we've put up sort of some links to resources. Our Duty of Care open letter to the Prime Minister is signed by over 3,000 healthcare professionals, and it really lays out a lot of the practical stuff we've been talking about. It, you know, the fact that this is just not this is not safe to put in the current system. You know, the safeguards will not protect vulnerable people, and actually this isn't the answer. So that's an opinion and a position and an argument by a large body of current healthcare professionals. There's lots of different groups. Obviously, you know, I've been accused of this is my view because I'm a Christian. And they're at the Christian Institute and Christian Concern. Christian Concern are organising a protest on the 29th of Parliament, outside Parliament, which is the day of the second reading. Christian Institute have put together some brilliant resources, but the resources aren't just Christian resources. They're interviews with palliative care doctors, with people who have, you know, experienced assisted suicide. You know, what they're trying to do is, obviously they care about the sanctity of life, and they want to preserve it. But it doesn't mean that all of their things are saying, and because the Bible says this, they've put the effort in to find the studies, to get them up onto a page so that people can read through them, so that we have informed consent, which is what, as UK Medical Freedom Alliance, we believe in informed consent. And I think that what we're risking is the whole country goes into this without informed consent. We have to know the risks as well as the benefits. And I think in the mainstream, you're very much hearing the benefits. And what a lot of these other organisations are doing, you've got Right to Life, I think that's a secular organisation. You've got Care Not Killing. So not all of these groups are religious groups either. There's plenty of secular people who are very, very against this for a myriad of reasons. You've got the disability rights campaigners who, you know, almost universally are against this because they see risks to the clientele that they are advocating for. So I think I would really encourage people to engage with the other side. I've been through the Dignity in Dying website, who are proposing this and who support it and think everyone should have the right, because I think we do all need to hear the other side, but so that we can come to an informed decision, and not that it isn't just an emotive response where we know how much in COVID compassion was used to sell a lot of very, very damaging measures. We can't allow that to happen again. We mustn't be naive. You know, we need wisdom here, and we need to see the big picture. I think that's what a lot of these sort of romanticised views don't present.
And I would like anyone that's obviously subscribed to my Telegram channel, our Substack, to please visit UK Medical Freedom Alliance for those resources. Nobody's telling anybody how to think. What we're saying is you can find resources and then you can come to your own decision. And if you feel that you do want to be part of the movement on the 29th of November, then there's obviously the resource there about how you would get involved in that. What I would also like to see, if I'm honest with you, is I think there's been very good engagement from doctors when you say the open letter. I would like to see lawyers get involved in this in the same way, bringing up the issues that I've raised about coercion, duress, the assessment of mental capacity, the time frames, the fact that you can have a proxy. We haven't got time to cover that, but I will be putting some more resources on my own channels about that. And what I think might be good for people as well is to know that this isn't our first rodeo with assisted dying. There have been various bills over the last 10 or so years. And I will put together a little bit of resources where people can go and look at the House of Lords debate about that, and the questions that were asked and what was brought up and why those bills failed at readings, at first and second readings and committee stages and things like that, so that people can then get a general overview of the questions that were looked at and asked. So I'll try to get that up quickly, and you're more than welcome to have a copy of that as well at UK Medical Freedom Alliance.
Definitely, that'd be great. So
Yeah.
much.
And if you could just drop me across all of your links, Claire, I'll make sure they go in the description below this video, and this will be uploaded as soon as we possibly can.
Fabulous, I'll do that. I'll drop you an email, and if there's anything else, like I said, I'm disappointed with the legal profession that they haven't come out and put something together for people so that they could at least be able to get a balanced view. They could even put both sides of it in and then raise what the concerns could be. But anyway, we are where we are with it.
Perfect.
Great.
Thanks so much, Claire. I've really learnt a lot just from talking to you.
Thank you. What I'll do is these notes that I just put together for me, I'll drop them by email to you and Iain. It's just got a little bit about the negative procedure and bits and pieces like that. So you might be able to get something out of it for the future then.
Excellent. Right. Well, thank you very much, both of you. It's been absolutely fascinating. As you say, learnt an awful lot, and we'll speak to you very, very soon, Claire. Thanks ever so much.
It's been my pleasure. Thank you for having me on. Really enjoyed it. Thank you.
Thank you so much. Thank you.